part of my practice is treating chronic venous insufficiency, and in layperson's terms, most people would think about that as varicose veins, spider veins, and also patients with swelling in their legs or tired and fatigued legs. What chronic venous insufficiency comes from is failure of valves in the veins. And if we think about veins being a series of roadways, that's an analogy I often use with my patients, bringing traffic back to a central location, that being the center of the body, chronic venous insufficiency occurs when there's congestion in those roadways from valves not working.
They do have the same genetics, and they might. What goes wrong with chronic venous insufficiency is often a genetic problem, and it's very, very common. Nearly 70 to 80% of patients will have a family member, first-degree relative, or an extended family member that has varicose veins or some sort of history of varicose veins.
I'm not able to walk like I used to because I walk my dogs, and my legs just feel super heavy, and so I kind of were not walking as much.
There's a common misconception that venous insufficiency or varicose veins are only a cosmetic problem, and this simply isn't true.
And the real problem is poor circulation in and out of the leg that can lead to downstream serious problems.
They also have impact on their quality of life in terms of the symptoms that varicose veins cause.
Anytime I sit down for any length of time, the pain is just really intense.
Left untreated, it can cause disease of the skin, and inflammation with cuts or wounds that don't heal for days, weeks, and even years. I found that with the use of the Closure Fast device, my patients experienced a significant improvement in their recovery within the first few weeks after the treatments.
VenaSeal offers patients who are active and who cannot take much time off work an ability to jump right back into normal activities without a compression stocking and without limitations placed on them by us.
Our blood vessels transport about 7,000 litres of blood every day. The veins in our legs carry blood from the lower extremities against gravity back towards the heart. The two most important mechanisms in this process are the calf muscle pump and the venous valves. During walking and exercising, our calf muscles repeatedly contract and relax. When they contract, they squeeze our veins. This pressure allows blood to flow upwards, thereby opening the venous valves. When inactive, the calf muscles relax, and the blood starts to flow backwards, thus causing the valves to close tightly and preventing further blood from flowing back to the feet. When veins become insufficient, however, they dilate and prevent the valves from closing properly. This in turn causes a reflux, which is when the blood leaks downwards and stagnates in the vein. If left untreated, this can result in the appearance of venous disease. Symptoms of venous disease vary depending on severity and may include itching, swelling, cramps, pain, and legs that feel restless or heavy. Meanwhile, visible varicose veins can also develop. Untreated varicose veins can cause inflammation of the venous wall and surrounding tissue, followed by the appearance of edema. Furthermore, blood cells can leak out of the vein into the surrounding tissue. This results in hyperpigmentation of the skin. The most severe form of untreated varicose veins is an ulcer. The major risk factor for venous disease is genetic predisposition. Combined with other factors, such as prolonged sitting or standing, obesity, advanced age, or pregnancy.
And venous disease is a common disorder. It's seen in greater than 80% of our U.S. population. Majority of the patients, about 70%, are women. 20 to 30% are our male population. The usual presentation is that of a sense of uncomfortableness, heaviness in your lower extremities. Patients often complain of some swelling, possibly discolorations. They may notice varicosities or bulging veins under their skin. Sometimes there's a burning sensation, a sense of itching. Occasionally restless leg syndrome that affects your evening sleep. So these are the frequent presentations of the disease, and there are treatable options available. I think the first thing that we do is coordinate an ultrasound, which will enable us to determine the extent and the complexity of your vein disease.
So chronic venous insufficiency occurs when our veins are not effectively returning the blood back up to the heart. There can be various reasons for this to occur, from genetic predisposition, time, jobs where we sit or stand a lot, weight can play a role in it, hormonal changes, age, all of these things can lead to that ineffective vein return. How our circulation system works is our arteries will take good oxygen-rich, nutrient-rich blood from the heart and deliver it to the tissues, and then our veins will return that deoxygenated blood back up to the heart and lungs. So the veins in our legs have the unfortunate task of working against gravity all day long. So we need a little help to support this blood return. So our veins have check valves in them, essentially. And when your muscles squeeze, when you walk and move around, push this blood up against gravity, valves open, When your muscles relax, valves shut to keep that blood moving in one direction back up to the heart and lungs. So in venous insufficiency, what happens is these valves become ineffective. The veins will kind of stretch and dilate for various reasons, which will allow too much of this blood to come back down the direction that it came from, which leads to a pooling of blood in the veins, which is where we can develop symptoms. Chronic venous insufficiency can cause a variety of symptoms, most commonly tired, heavy legs. It can also cause a restlessness, cramping in the legs. We can see swelling, and perhaps even in more advanced stages, you can see skin changes from coloration to actual tissue damage and hardening and thickening of the skin. When we treat venous insufficiency, our main goal is symptomatic benefit. We want to make patients feel better. And then in turn, that can also improve swelling and also in some cases the appearance of the legs as well. So when we treat veins, we are essentially closing down these inefficient pathways, and your body will then naturally redirect that blood flow to all of the efficient pathways that you already have in place. So the most frequently asked question I get is, will insurance cover this? And for a majority of patients, yes, it will. There are very few insurers that don't cover venous treatment anymore.
We have a team in each office that will take the treatment plan that was put together by Dr. Town and your provider. We take that, we get with your insurance company, and depending on your coverage, so that could be your deductible, your co-insurance, or copay, would be the determining factor what your out-of-pocket expense would be. Before you come in for the actual procedure, we would notify you and discuss that coverage with you in great detail. If for any reason you're unable to pay what you would owe out of pocket at the time of service, we do have several options that we could offer you so that you could still get the medical treatment that you need, but not feel that financial burden. We do offer something that's called Care Credit. It is a credit card strictly for medical bills. It's free to apply for, and we can do it in the office, and it takes just a matter of minutes. We have some other options that we could offer too if we need to do any type of in-house payment plans. But again, we do have financial teams at all locations that are more than happy to sit down and discuss with you what your insurance would cover and what your out-of-pocket expense would be, and to make sure that you're able to be treated medically.
We'd like to compress most therapies. Ideally, it would be best to have everything taken care of on day one. Very frequently, the complexity of your disease requires a need for numerous treatments. Our insurance carriers have limited us in terms of what can be done and what cannot be done. Very frequently, by doing one procedure, may limit the need for additional procedures, and that's the need for follow-up ultrasounds and repeat studies. That way, at the conclusion of the treatment, we know that we've covered all of your venous pathology and all of your venous disease. Unfortunately, vein disease, as we had indicated, is a chronic disorder. It's often necessary to consider all additional forms of therapy. Most of this is determined on the basis of your initial response to our first treatment. Multiple treatments may be necessary.
I also get asked a lot, will this hurt? That seems to be high on everybody's list. And for most people, the most frequent thing that I hear when we're done with procedures is, was that it? They're expecting more pain and discomfort, and really it's not bad. So with any procedures that we do, we are creating some inflammation and irritation in the vein to get them to close down. So we do expect some temporary mild discomfort, swelling. You might have redness or tenderness to touch. Most of these symptoms can be controlled with simply ice, ibuprofen, Tylenol, and compression socks.
Your expectations in terms of pain are very limited. It obviously varies with individuals and the procedure that we perform. We anticipate a 3 to 5 day period of soreness, mild tenderness, most of which can be managed with mild anti-inflammatories. Occasionally, a phlebitis, which is a complication of our procedure, may need additional analgesics or pain medication. Compression therapy, along with continued activity, limits the number of your complaints.
Another question I get asked very often is, when you close a vein down, is that good? Don't I need that vein? And the truth is, if it's working as it should, then yes, absolutely. We don't want to go around closing down efficient veins. But when this vein is abnormal and inefficient, it's better to close that vein down and allow our body to naturally redirect that blood flow to the healthy veins. Most of our venous return is done through our deep venous system, and we are not doing anything to our deep veins. We ensure that our deep veins are open and healthy, working as they should on your first diagnostic ultrasound, which tells us we can close down these inefficient veins, and we have plenty of other veins in place that will compensate.
Following your procedure, we outline a very carefully planned treatment. And the treatment often requires more than one procedure. Some of the procedures are brief, requiring simple needle injection with a sclerosing agent. Other times, given the complexity of your disease, requires additional procedures for completeness.
Another frequent question is, will I have to wear compression socks? With some of our procedures, you do not have to wear compression socks afterwards. With most of them, we do encourage it, but it's a short course, maybe 5 days to 7 days after procedures. So one option for treatment is radiofrequency ablation, and this is done here in the office, and we are using a catheter that we put inside the vessel that will apply heat to the vessel wall to irritate and scar down that vein. It generally takes us about 15 to 20 minutes to do the procedure. You will have a few needle sticks to numb up around the vein. After the procedure, we will have you wear compression socks for a short period of time, but you should be back, return to your normal activities within 2 to 3 days after procedures. Another modality for treatment would be Varithena, which is an injection of medication into the vein. You mix this medication called polydocanol with a compressed gas that will create bubbles, and those bubbles help to deliver this medicine to the vein wall to create irritation and get that vein to scar down. This is a quick procedure. We just look with ultrasound to find a good access site and a very small needle stick directly into the vein, and then you inject that medicine. VenaSeal is a catheter-based treatment in which we are using a medical-grade adhesive to seal that vein off. It is done here in the office. We would sterilely prep the leg. We look with ultrasound to find a good access point to get into the vein. You get a small shot of numbing medicine, and then we advance a catheter into the vein and follow with ultrasound to have it positioned where we want it. And then you deliver this VenaSeal through the end of that catheter and hold gentle pressure to the leg as we deliver that down the leg. This procedure usually takes us about 30 to 40 minutes, and very quick recovery, have you back up and to your normal activities the next day. Another treatment option would be ultrasound-guided foam sclerotherapy. This is using a medicine, polydocanol, that we mix with room air to form bubbles, and we inject that into the vein. That medicine will come in contact with the vein wall to create irritation and get that vein to scar down. This procedure is very quick, usually takes us about 10 minutes to do, and you can have a little bit of pain and discomfort as these vessels are a little closer to the surface, but this is minimal discomfort over the next 1 to 2 weeks after procedures. Phlebectomy is actually removing some of these very large varicose veins close to the surface of the skin. A lot of people don't like the idea of removing a vein, but I hear very frequently that it's not nearly as bad to experience the procedure as people anticipate. We just numb up around the vein. You make very small little incisions right next to the vein, and we have hooks that can hook that vein and pull sections of this large vein out through those small little incisions. It does not require any stitches. We just simply cover those small incisions with little steri strips and then apply a bandage to the leg. And normally you are back to normal activities within 2 to 3 days.
So at the vein company, we see a lot of patients that have had leg swelling for years and years. So they come to us looking for answers for the cause of their leg swelling. A lot of times we see that in conjunction with chronic venous insufficiency. That's called phlebolymphedema. We also see it as a result of damage to that lymphatic system. So when your lymphatic system becomes damaged through surgeries, chronic illness, chronic venous insufficiency, radiation, chemotherapy, you will present with leg swelling or swelling in the arms, swelling in the abdomen. So your lymphatic system is made to remove waste from the body. It's like a drain system. So if you have a drain system that works as it should, as it rains, fluid, the rain is going to go into that system and it's going to be carried off. If you have a drain system that becomes clogged or is no longer operable, then you're going to have a buildup of that rainwater that comes back. And that's like the lymphatic system. If your lymphatic system isn't working correctly, you're going to have a backlog or a buildup of fluid that's going to go out into that tissue. When it goes out into that tissue, it's a protein-rich fluid. Over time, if you don't seek intervention early, that fluid is going to cause your skin to become fibrotic or hard. When that skin becomes fibrotic, then it's hard to do the things that skin is meant to do, which is to protect the body. That's our Band-Aid. That's God's way of protecting our body. So when that fibrotic skin is there and you get a cut from a dog scratches you or a baby scratches your leg, it's going to set you up for the risk of infection. So that's why with lymphedema, it's very important to monitor your skin, to look for any open areas, to make sure that you are caring for your skin in the proper manner. So as we age, we think that swelling of our legs is a normal aging process, but it is not. We think, oh, we're getting older, so we're just going to have to live with that. We'll prop our legs up, we'll reduce our activity, we'll reduce our exercise, we won't go out to outings, we don't participate in things with our family because we have swelling in our legs. And it doesn't have to be like that. At the Vein Company, with our certified lymphedema specialist, we can provide long-term solutions to help you get back your quality of life. So lymphedema is a disease that has not been talked about routinely over the last 10 years. Over the last 5 years, we've had a lot of new literature that has come out because this has become a very prevalent disease. In the United States, it's estimated that more than 10 million people are affected by lymphedema. That is more than ALS, muscular dystrophy, MS, Parkinson's, and HIV combined. If untreated, lymphedema can lead to chronic, non-healing ulcers. So in the United States, the most common cause of lower extremity edema is actually called phlebolymphedema. Phlebolymphedema is actually chronic venous insufficiency and lymphedema combined. So you need to address both of those to have the best outcomes.
So we get a lot of patients in here with leg swelling. So leg swelling is usually from a combination of issues, starting a lot of times with chronic venous insufficiency. So our veins are ineffective and that leads to pooling blood. That creates inflammation and puts stress on our lymphatic system, and then our lymphatic system in turn does not work as effectively. So what we like to do is start by treating the venous system. That may or may not create a lot of improvement with the swelling. We bring you back in close follow-up so that we can see how much improvement we had by just treating the venous insufficiency. If we've not had the improvement that we need, then we concentrate on treating the lymphatic system. I will a lot of times explain it like you've had a river That's your venous system that's been flooding. That flood will damage the tissue around it. Well, just because we get the waters to recede, that does not mean that your land's going to go back to normal. So sometimes we have to specifically address that land around it, and that's what we do when we treat the lymphatics. So when we're treating lymphedema, there's unfortunately nothing that we can do to cure it, but we have lots of options to manage it. And the cornerstone of treatment is compression. So we can work to get you in good fitting compression that you can tolerate. Thankfully, Medicare is now covering some of these compression garments, which has been a huge help to patients. And then we can also work with manual lymphatic drainage, different exercises that patients can do at home, and possibly even a compression pump, which would be something that you would have at home, maybe wear 1 to 2 hours a day. That it's a gentle leg massage essentially to help push that fluid up to the lymph nodes for your body to expel it. Like most things, insurance helps to direct treatment. So we have different pumps that we can use. Ideally, a second generation pump tends to be most effective for patients, but we need to start with the basic model and see how patients respond to that before we can go to a more advanced pump model. The best thing about the advanced pump is it more closely mimics your true lymphatic system. And so long term, that's something that you can use when we have an incompetent lymphatic system. We can't make that lymph system work how it should, but we have an option to externally mimic the same return.
With daily use, we have seen patients have dramatic results and get back to living life. By addressing both the venous system and the lymphatic system, our patients have a much better quality of life. Since this is a chronic condition, we're going to help you long term to get back your quality of life. Venous disease and chronic leg swelling is very common. If you have one or both of these conditions, you're not alone, and we are here to help.
My name is Dr. Bob Foster. I'm an interventional cardiologist and practiced for 25 years, specialized in arteries and veins of the body and opening those up, and sometimes we have to close those down. So really excited to be here as part of the vein company. So one of the problems that sometimes happens that's pretty common is that you have progressive swelling of the legs or discomfort of the legs or changes in the color of the legs. All that can be due to pressurization. So basically you have high pressures in the legs. Sometimes that can be due from weak valves in your legs. Those are the shallow veins, and many times we have ways of closing those down. But sometimes they're due to compression. And the problem with compression, and it's in your deep veins, the problem with compression is that whenever those vessels are compressed, then the pressure in your legs builds up. And as that pressure in your legs builds up, then you start getting the swelling. And you can treat the shallow veins all you want to. It's not going to help till you relieve that pressure. It's kind of like a dam. So basically the water's dammed up and everything else is pooling or laking in your legs. The other analogy is kind of like a hose pipe. Whenever you pinch a hose pipe, that pressure backs up. So what happens is when people start standing or sitting for long periods of time, the pressure builds up in their legs. And it's not just the legs, it can sometimes be the pelvis. So it can go into your abdomen, and the reason for that is because blood's trying to get around that blockage. And the way it does that is goes through all those pelvic veins. So it can cause a lot of pelvic discomfort. So people who have a lot of pelvic pain many times can have this. And basically what it is, the vein is a very thin-walled structure. So you have a thick-walled artery compressing a thin-walled vein against your spine. And it's usually just the way that you're born. It's not a problem with the vein itself. It's not a blockage in there many times. Most of the time, it's just a compression. So what that vein needs is a little bit of support. So what we do is we actually go in there and we put a stent in. So let me tell you how you put a stent in. Sounds terrible, but it's very easy. These stents are very, very small and they're on catheters themselves. So what we do is we bring, it's an outpatient procedure. You walk in, you actually walk to the table, lay down on the table. We use x-rays to image kind of where we're going. And once we numb the skin of your leg up, then we slide these little sheaths in. Sheaths are like little IVs. So they go in your leg, we slide a little catheter in, and then we just take a picture. And so we just inject some dye, we use the x-ray machines and see if there's a narrowing there. The narrowing on the x-ray, a lot of times, it can look like a typical narrowing, which you might see if people have blockages in their neck or blockages in their legs. But in the veins, many times, it's like a compression, like a flattening. So if we see that, then you can't also tell how bad it is until you look at it from the inside. So through that same little catheter, we slide another little catheter that has ultrasound on it and look at it from the inside and actually measure the size of the blood vessel, how big it should be, how much it's compressed. That tells us what size stent we need to put in and what length of stent we need to put in. The stent basically just holds the vessel open. And when it holds the vessel open, it unloads the legs. And when that unloads the legs and it has straight line flow, so the artery's carrying it down, the veins will carry it right back up. And then that depressurization occurs. And then you see all that pressurization come out of the legs and come out of the abdomen. And that's what really helps people. The typical symptoms you get are severe leg pain, usually in the evening, swelling of the legs, and the most typical one that we see, and if you have this, you very likely have it, is if it's all on one leg. So if one leg is really swollen, but the other leg is not, then something's going on. Both your legs should have been exposed over your lifetime to equal amounts of pressure and equal amounts of problems. And so it's very rare that you have one leg that's a problem and the other one is okay. So whenever you see one leg swollen, then that's what we think about. Now there are other causes of that. It's not just May-Thurner. Sometimes people have blood clots in their legs and they partially heal, so they get scar tissue there. And then there's another disease that's basically just people are just born with a small, thin vein. It's called Rokitansky vein. And that's basically, they just never develop that vein, so it's always a little bit smaller, so that leg always swells more. The problem with that is that blood flow coming back up gets sluggish and slow, so it makes you more prone to having blood clots. So it's a very high risk for having blood clots if you have really slow flow out of one of your legs. So on procedure day, we're not doing any cutting, we're not doing any stitches, this is all through little catheters. Catheters are like little tubes. We just slide those little tubes in after we numb up the skin, and we give you a little medicine to help you relax. Okay, so it's not something that you should be fearful of. It's not a painful procedure at all. So basically, once we numb you up, we slide these little IVs in. Through those IVs, we inject some dye and just see if there's any narrowing. If we see some narrowing, then we go in with an ultrasound catheter. Teeny little catheter just goes through that little sheath that we put in, and we just image it from the inside. From that, we can tell the size of the vessel and the size of the stent we may need to put in, and the length. We can measure the length of the stent we need to put in, so that we can precisely put the stent where it needs to be and at the right size and covering the whole blockage, which is very important. So after that, we slide the little sheaths out of your legs, hold a little pressure. Again, we're dealing with veins, so these are like big IVs. We're not dealing with arteries at all under a lot of pressure. These are a very low pressure system. We slide it out, hold pressure for a few minutes, and then we take you to recovery, watch you for about an hour. Get you up, watch you for about 15 minutes. If you do okay with that, we let you go home. Again, if you're going to have you may have a bit of bruising, but that's really about it. It's not a painful thing. We ask you not to lift heavy objects for about 2 or 3 days, just to kind of make sure that you don't have any problems from your groins, but that's really about it. Not much of a recovery process at all. As far as when people get better, I've had people get better the next day, and they just say, wow, the pressure's off my legs. It feels a lot better. Most of the time, it takes a little bit of time. It takes a little bit of time for that pressurization to come down, for those blood vessels to start to shrink, for the lymphatics to start to shrink. And then once that happens, that's when they start seeing a noticeable difference. Typically, we like to see it about a month, and we expect that probably about half the patients will show some signs of significant improvement in a month. Most of the time, it's 3 to 6 months. At the 3 to 6 month mark, if you're going to get any symptom relief, it's going to be in those 3 to 6 months. And at the end of 6 months, that's probably whatever you're left with. Post-procedure, we are putting you on a blood thinner afterwards. And this blood thinner is like an aspirin. So it's not a systemic blood thinner like you normally think of. It's called Plavix. It's like a turbo aspirin. So we put you on that. And again, we ask you not to lift anything heavy. That's really about it. There's no sutures or anything to deal with. You'll take one of these tablets, one of these Plavix every day. Plavix is like a turbo aspirin. So if you bleed a little bit on aspirin, you'll bleed a little bit more on this if you bump yourself or cut yourself. But that's a normal thing. And we have a lot of people, especially anybody who has a stent in their heart or a stent in their neck, are on Plavix, usually lifelong. And so we have people on Plavix for long term, and they do well with them. For this, it's 3 months of Plavix, and then you just take a baby aspirin. that baby aspirin once a day. After, if you need to come off it for a back block or you need to come off it for surgery, you can come off it. It's not like if you miss it or don't take it, your stent's going to have a problem. These stents are very large, and so the likelihood of a stent re-narrowing is almost zero. It's almost as close to zero as any stent we put in the body. Okay, it's not zero, but it's as close as zero. Because basically all we're doing, we're not really treating a problem with the vein, we're just treating with something that just needs a little bit of structure to it. And the bigger the stent, the less likely it is to have a problem. So stents in the heart are typically 2.5 to 3.5 millimeters. These are like 18 millimeters. So these are 18 to 20 millimeters. They're big stents. As you know, most of the procedures are now moving to the outpatient. And one of the things that we're doing, very complex procedures in the hospitals, and with that we have to wear heavy lead aprons. With these procedures, the only way that we can see inside the body, and that's been the great invention of X-ray, is that we can see inside the body without cutting you open. But the problem with seeing inside your body, we have to use those X-rays. Not a problem for you as a patient, because you're getting it once in your lifetime, or maybe 5 times in your lifetime if you have a procedure in one of these labs. But we're in there every day, and our staff are in there every day, and we're getting an enormous amount of radiation. So as we're getting that radiation that's hitting our heads and hitting our bodies, we have some protection on our body, but the problem is it weighs 18, 20 pounds. And wearing that much lead, there's about 60% of the time we get disabling back injury after we've been in the lab for 20 years. And I've lived that out. My 21st year, actually when I was in my, 18th year, I had my first back rupture. When I was in my 21st year, I had my second disc rupture. So required 2 surgeries. The next thing is back fusion. So we had to find a solution that's not the lead apron. And that's where the Rampart comes in. The Rampart is something that we developed about 5 years ago when we went first commercial product. And basically it allows you just to bring it into the lab. It's made out of same thing your lead apron's made out of, except we're taking it off your body and we're just putting it between you and the radiation source. So you and your team can come out of lead. So it allows you, as long as you stand in the shadow, which basically the way radiation works, it comes up and hits the patient and then scatters into the room. And what gets us is that scatter. So we know if we've been in the lab for 20 to 30 years, we get the equivalent of about 50 to 75,000 chest x-rays is how much x-rays that we've gotten in our lifetimes. And many of us are dying of left-sided brain cancers, and we have skin cancers, and a lot of us don't have hair on our legs on the left side just from radiation over time. So it's a very dangerous thing. So rather than wearing that lead, we actually multiply it times 2 to 4 and put it in lead acrylic that's supported by the floor. And so basically you're just standing in this shadow. And as long as you and your staff are standing in the shadow, they don't have to wear the lead apron anymore. So this is the first outpatient lab in the world that cares about their staff enough and cares about their operators enough that will protect them long term. And that's very, very important because the staff is important. If you want a good outcome, you want well-trained operators, you want well-trained staff, and unfortunately they're moving on because they can't wear the lead apron all that time. And a lot of women are worried about the fertility issues of being exposed to radiation day in and day out. So this allows you to have this wall of protection in front of you. This is the first lab in the world that is outpatient that has adopted that. And that's great about the Vein Company.
So in the broadest sense, an ulcer is just a wound or a break in the skin. But when we're talking about wound care, there's a lot of different types of ulcers. The 2 biggest ones are ulcers that are caused by a poor blood flow to the limb, or an arterial ulcer, or a venous ulcer, which is caused by poor return of blood from the limb. There are a lot of different reasons that the patient brings with them that make wounds difficult to heal. When we're young and we skin our knees, wounds heal easily because our bodies are young and we're healthy. As we get older, we all have different diseases, and those diseases can make wounds very difficult to heal. If you have poor blood flow to your leg, then you'll have an arterial wound that might be difficult to heal. You can do a lot of different things to that wound, but if you don't improve the blood flow to the wound, it's never going to heal. Same thing with a venous ulcer. If you've got poor blood return from the leg, then you can treat that wound with whatever you want to treat it with. But if you don't do the right things and improve that blood return from the limb, it's probably not going to heal, or it's going to take a very long time to heal. And then there are other things like diabetes, and medications that can sometimes make wounds very difficult to heal. Why am I coming to the vein company to get my wound taken care of? My doctor's managed it for years. So what are we going to do different? Well, that's a very important question because there's a lot of different things that we can do for the wound that your primary care physician may not be able to do. And it's important that we do all of those things that they were doing, but we add on some of the more advanced techniques. We have tissue replacement techniques. We have interventional techniques to improve that blood flow from the limb. We've got a staff, which is the most important thing, that is very knowledgeable about the different types of wound supplies and how to use those. 25, 30 years ago, everybody got the exact same dressings. We can do a whole lot better than that now. One of the big things that we do is we apply different types of biologic dressings. Now, what a biologic dressing is, it's a tissue culture. So we've cultured skin tissue and we use that to replace the skin that you had. So it sounds really easy, you know, we're just going to take some other skin and we're going to put it on your wound. Well, that's not really the way biologics work. Biologics work because that tissue we put on there, those cells die, but they release special factors into the wound that helps your body recognize that this wound needs to be healed. When a wound's been open for a long time, the body just gets used to it. And the body says, oh, I've got this wound, I'm just gonna leave it here forever because it's been there for a year. So we have to do things to kickstart that. Some of those things we can do with just good debridement, but sometimes we have to apply different types of wound dressings that will help to kickstart those wounds and get them working again and get your body doing what it needs to do to heal that wound. How long is it going to take my wound to heal? That's a very difficult question, and every wound heals at a different rate. If I could tell you how long it was going to heal, I would tell you. But our goal is to heal that wound as fast as it possibly can. Some people have had wounds that have been open for years. Some people have wounds that just started. But in general, we'd like to heal the wound within 6 to 12 weeks. It's important that we get to see how wounds react to the treatments that we do. And that means that we have to see you back multiple times. In general, we're going to want to see you on a weekly basis. It's important that we clean the wound, both surgically and with different kinds of dressings, to get the wound clean so that the wound can heal. It's important that we address problems that are occurring with the wound on a rapid basis so that those wounds can continue to heal. We ask that you come back every week. Some wounds can be done every other week, but in general, you're going to be coming frequently until we get a good handle on that wound.